So today, Dr. Scholes, we're talking about PSA and chemotherapy. And the whole concept is how PSA can help determine whether chemotherapy is effective and the timelines of how this should look. The other part of it, if you can discuss this at the beginning, is kind of, chemotherapy by, common standards is kind of known as this really rigorous, terrible treatment. I'm going to go bald and all these different things. And I think in prostate cancer, we think of chemo as very different, but maybe the viewer has a different perception of what that is. So can you clarify that for us?
I appreciate you bringing that up because chemotherapy is just a general term for usually injectable, sometimes oral medicines that poison the cancer cells. And cancer cells are very similar to our own cells. They are derived from our own cells. And so collateral damage to our normal cells, you mentioned hair loss, for example, is very common with the things that we call chemotherapy. But the range of different protocols, because chemotherapy may be a single medicine, as it is in prostate cancer, usually Taxotere or Jevtana, or it could be a panoply of 3 or 4 medicines. When we treat Hodgkin's disease, we give 4 different chemotherapies simultaneously. So the range of what we call chemotherapy is very broad. And if you look at on that spectrum of complex combination toxic therapy to cure leukemia, and then single agent, relatively tolerable or milder treatment like Taxotere for prostate cancer, there's this big spectrum. And people should respect chemotherapy because it certainly can have some side effects, but chemotherapy for prostate cancer is pretty tolerable, and usually it's administered for a fairly short period of time. If it's given in an ancillary setting, we call it adjuvant, to try and improve cure rates for someone who has early metastatic disease, they may only get 4 or 6 injections over a 12 to 16-week period. If they have advanced disease, they maybe get 4 to 6 to 8 cycles, depending on how it's working. It is much more tolerable. It's not something that you go rushing into, but thankfully, these medicines, Taxotere and Jevtana, are quite effective. And if the setting calls for it, people shouldn't be hesitant or nervous about the medication, especially since you can try one treatment, see how you personally respond. There is some variability from individual to individual. So try one treatment. If it doesn't go that well, it can be discontinued, and the side effects will wear off. So it's overemphasized the seriousness of chemotherapy just because I think in other disease types, the type of medicines and the combinations that are used are usually far more toxic than what we use in prostate cancer.
Before I get to my next question on chemotherapy and PSA, I just wanted to remind you that we are a 501c3 nonprofit organization, and all of the videos on our channel are brought to you by viewers like you who have donated. They have joined our cause in educating prostate cancer patients all around the world. If you would like to join our cause, you can visit our website at pcri.org/donate. The link is also in the description below. Thank you so much for listening, and now back to the video. What are the differences between Jevtana and Taxotere, and how are they used in real-life settings?
They're much more similar than different. These are injectable medicines typically given every 3 weeks for a total of 4 to 6 injections. The primary difference between Jevtana and Taxotere is in head-to-head studies, they were shown to have equal anti-cancer effects, but Jevtana in more than half the people was described as having fewer side effects. So less neuropathy, less fatigue, less GI side effects than Taxotere. It is not generic the way Taxotere is, so Taxotere is a much more affordable type of chemotherapy compared to Jevtana. If insurance will cover Jevtana, that would probably be my first choice.
So you mentioned side effects like neuropathy and fatigue. What other side effects could come from these types of chemotherapies?
Well, you already mentioned hair loss. Hair loss is not universal with Taxotere and Jevtana, but it's common. Using an ice cap can be considered. These are typically not covered by insurance, and properly administered, they're a little bit pricey, but they do work. Other side effects are, in the old days, nausea and vomiting was associated with chemotherapy, but modern anti-nausea medicines essentially eliminate that at this point. So we rarely see nausea or vomiting. What we wrestle with in the administration of these medicines primarily is fatigue, which the onset is usually a couple days after the injection, lasting for 2 to 5 days. And that can partially be offset with fitness, just like we compensate for fatigue from radiation or from hormone therapy with fitness. Resistance training, going to the gym, and that should be part of the program. It's oftentimes difficult because the degree of fatigue can be very noticeable, and the last thing you want to do is go to the gym. But people that are able to go and at least do some light lifting during their chemo protocols do much better, feel stronger, and endure the whole process much more successfully than those that don't.
Can you explain why the ice cap would be successful in hopefully helping with hair loss?
Yes, so when they inject medicine, Jevtana or Taxotere, into the bloodstream, it circulates around in all corners of our body. And when you have a portion of your body that's cold, the blood doesn't circulate there. The body naturally restricts blood flow to that area. So the scalp has a lot of blood flow, and if you put a ice cap on the scalp, it causes blood to not come to the scalp, and therefore the hair roots are not touched by the Taxotere or the Jevtana, which is in the bloodstream. The same thing is true for trying to offset taste abnormalities. Taste buds are sensitive to chemotherapy, and when people are taking Taxotere and Jevtana, it can make food taste funny. And so we counsel people to keep some ice chips in their mouth during the infusion and for about 30 minutes afterwards when the chemo is still circulating, and that helps reduce the risk of changes to the way food tastes. There's also, at least in weekly protocols with Taxotere, sometimes we'll give small doses of Taxotere in elderly people on a weekly basis instead of every 3 weeks. So that makes it even more tolerable, but there is a greater propensity for problems with fingernails. So the rapidly growing cells of our body are more susceptible to chemotherapy, which is an anti-growth medicine. If you keep your tips on some blue ice or something like that during the infusion and for a short time afterwards, that reduces the likelihood of problems with fingernails.
Are these practices, when it comes to your salivary glands or your fingertips or ice caps, common in community settings, or do you typically see these in like academic centers?
I think it's very spotty. Our awareness, of course, grows out of the fact that we only treat prostate cancer, and so we have a large repetitive thing going on. We started using Taxotere long before it was FDA approved, probably back in 1998. So these little refinements, I think, are understood in certain centers and overlooked in other centers.
So now talking about PSA. So let's talk about it in a setting where somebody maybe is in a more advanced category and maybe they're, doing chemo after they've already done hormone therapy. If you have a rising PSA, what effect will we see chemo have on the PSA itself?
So more than half the time, in parentheses, not everyone that goes on Jevtana and Taxotere will respond, but probably 2 out of 3 people will. And you should observe at least a stabilization of PSA, if not a decline in PSA, a few weeks after the second injection. So if you're getting an injection every 3 weeks, we typically will allow 2 injections plus a little more time to see if the PSA was rising on a steady basis, which is almost always the case, that there should be at least some leveling off and possibly some decline. And if we see a leveling off, I think that is plenty of evidence that you're getting benefit. We talked about all the side effects from Jevtana and Taxotere. We want to see a benefit as a result of going through the trouble of going to the doctor's office and having a medicine that can cause some fatigue and hair loss. And we will see that reflected in the PSA. So if the PSA continues to rise in an unremitting fashion after 2 cycles of 2 injections in a row, then it's time to look at a different option. The Taxotere or the Jevtana apparently in that individual is not working.
For patients who are in community settings, sometimes we see that the PSA is a little higher because the doctors are maybe not, going to the next treatment as their PSA is rising. For higher PSAs, do you see a sharper decline with chemo, or is it pretty steady across the board?
Pretty steady across the board. It's not dependent on how high the PSA is. It's dependent on whether that individual's particular genetic type of prostate cancer will respond to the medication. There are just many different types of prostate cancer. More than half of them are susceptible to Taxotere and Jevtana, but some are not. And it's just a matter of which type of prostate cancer it is. And people say, well, how do you identify these types? We identify them by treating people and finding out if it works. It's a trial and error process. We haven't figured out the genetic signature yet where you could do a blood test and tell people with certainty it will work in you or it won't work in you. That would be a wonderful thing if we did have that, but we don't have that at this point.
So after the 6-week mark and you have patients where there is a decline, how long till maybe we see that the PSA does, hit a PSA nadir, it's low, we're good and we're steady? Or, and what percentage of patients do you see that happen?
Probably 2 out of 3 people respond and get some benefit out of these medications. But I think what you're angling at is how long do you keep going if it's working? That is a judgment call based on how well the medicine is tolerated, how much the PSA is declining, and what kind of other alternatives do you have if you were to stop the treatment. There is a policy that's semi-validated of so-called intermittent chemotherapy, intermittent Taxotere Jevtana, where men may go for 4 to 6 to 8 to 10 treatments given every 3 weeks, and then take a holiday, depending on how well they've responded. You asked, do we ever see PSA go down to undetectable levels or zero? Yes, it's not common. When you look at the studies reporting the efficacy of chemotherapy, it's whether or not the PSA declined at least 50% from the starting point. So if the PSA was 100 when someone started, if the PSA goes down to less than 50, that's defined as a response in the literature. We believe, of course, there's a value to just forestalling further rise or even slighter declines, but you'll tend to see longer responses in people that get the PSA at least 50% below the starting point when they had their first injection.
So if you have a situation where maybe the patient did have, let's just say, like you said, 100, their PSA is 100, it gets to below 50. How long do they maintain that? Are they just trying to stay on intermittent chemotherapy and keep it below 50? Are we still trying to go to zero? Is there other medications that you would add in order to try to get it to zero? What are the options at that point?
Yeah, I would say that people continue to pursue the injections on an every 3-week basis as long as you're seeing significant incremental declines in PSA from cycle to cycle, and as long as the side effects are not excessive. So, there are some people that tolerate these medicines poorly. They're not common, but they happen. So it's a trade-off between the quality of life and the progress that you're making. If the PSA, say, were to come down to 20 or 30, and you get a couple of PSAs in a row where it's sort of fluctuating between 20 and 30, in other words, stabilizing on treatment, then the question will arise, is this something where we should continue the treatment on an ongoing basis to keep the PSA stable? Or should we take a holiday with the expectation that the PSA will probably start rising without the ongoing administration of the therapy? And that usually comes down to a personal choice between the physician and the patient, having a discussion about what kind of side effects are, if if the medicine is very well tolerated, it's tempting to just stay on the medicine and keep the PSA suppressed. We know that it's holding the disease in abeyance. If the medicine is exacting a high price in terms of its side effects, excess fatigue or whatnot, then maybe it's time to take a holiday, restore your energy levels, get back to exercising, and then the treatment can be resumed if the PSA turns around and starts rising while you're off treatment.
I think that there is a lot of concern I see with patients when they call the helpline and maybe they're on chemotherapy, but the PSA, let's just say it's hovering around 20, but it's not going down to zero, and they think, okay, is the prostate cancer growing because the PSA is 20? Can you speak to that?
We have acted throughout the years as if it's not, that a stable PSA is almost a universally good thing. However, we know that that's probably not a universal truth. And the good news is with these new PSMA PET scans, if one has been obtained at baseline before starting the chemotherapy, and then if they're administered periodically when people are getting the chemotherapy, we can ensure that there's no new spots showing up. So the concern would be that if you're killing off a large percentage of the cells that are sensitive to chemotherapy, but at the same time you're not affecting a small subclone of chemo-resistant cells which continue to grow, that even though the PSA is stable, what's happening over time is that a more serious type of a problem is looming down the line that's not being controlled. And that's the beauty of these new PSMA PET scans, is that you can detect that type of a problem earlier rather than just waiting for the day of reckoning when the PSA is rising because of that subclone progressing right through the chemotherapy. So we always want to find out what's going on earlier so we can address it. Maybe that is just one spot that's not controlled, and we could deliver some spot radiation and eradicate it and get a benefit from combining the chemotherapy with spot radiation should a subclone be present.
Where in the timeline should a patient get a PSMA scan? Is it before they start chemo and then like maybe after 3 or 4 treatments they're seeing if the chemo is effective? What's your typical protocol?
Well, this is evolving because these scans are new, but we certainly want to have a scan at baseline, the starting point, and then I would think that we would want to repeat the scan if we reach a nadir. So if we're using our example of a PSA of 100, now the PSA is banging between 20 and 30, and Taxotere is being administered every 3 weeks on an ongoing basis, and we want to have a sense of where we stand. I think that's a logical place to get another PSMA PET scan, compare it with the baseline scan, see if all the spots are regressing, and if there are any new spots or any that are growing, perhaps consider delivering spot radiation to eradicate them.
If we're in the situation where the patient has been on chemo and now their PSA has some stability, maybe it is bouncing, like you said, between 20 and 30, is there any benefit to, changing to a different chemo? I've read about carboplatin. How does that play out?
So that would be a logical consideration. So it seems like you've kind of reached a stability point, and let's say this particular patient is tolerating the medicine quite nicely, and they say, I can keep doing this. This is great. My disease is stable. Should we add something additional to try and further cause more decline in the PSA? And I think the logical thing to talk about would be carboplatin, which is another type of chemotherapy that's FDA approved for the treatment of lung cancers and other cancers, ovarian cancers, and often has efficacy in the prostate cancer world. It can be given along with a Taxotere. We usually use relatively small doses because in large doses it can have significant side effects. But in small doses it can be effective and well tolerated and not particularly expensive. So it's something that can be administered either on label or off label to try and get further horsepower. The other option, of course, is to switch from the Taxotere to the Jevtana. From a response point of view, I'm not convinced that that switch makes a lot of difference. I think they're both pretty efficacious. It is possible that the Jevtana will have a little more horsepower just because it's a different medicine than the Taxotere, so you're keeping the cancer off balance, so to speak. We'll oftentimes switch to Jevtana even earlier just because of its profile of having somewhat less side effects. So many doctors want to use Taxotere as long as possible and, quote, keep their arrow in the quiver so they can switch to Jevtana at some point to say the PSA stabilizes and switch at that juncture. But because of the better side effect profile, we'll oftentimes switch to Jevtana earlier just to reduce side effects.
We have a lot of patients who are watching and they're maybe not going to like a large university, maybe they're receiving chemo in maybe a smaller hospital setting. A lot of what we're talking about when it comes to intermittent chemotherapy, I wouldn't imagine is something that their oncologist is going to bring up. So what are a couple tips that you can give patients on how to have that conversation with their oncologist?
Honestly, I don't see a big difference between prostate cancer management in the community setting compared to the academic setting. There are strengths and weaknesses to both settings. The community setting tends to be much more flexible. The academic setting tends to be very rigid. So you could say, well, it's rigidly correct. But medicine is changing very quickly, and there's a need for the doctors to have an open mind to all these new developments that we're facing. So I think that being aware across the board, not just for people with advanced prostate cancer, but all stages, that the doctors that you'll be seeing have a variable understanding of prostate cancer, not because they're bad doctors, they're just stretched very thin. They're seeing a lot of different cancer types. There's a lot of new information out there. I think that's the role that PCR is trying to fulfill, is to help patients educate themselves so that they can have these discussions and investigate all the many available options that we have now.
So today we talked about chemotherapy and we talked about PSA. We also talked about intermittent chemotherapy, switching chemos, and the side effect profiles. All of this is really good information to have. But as you've heard Dr. Scholl say, the PSA is a huge component of determining whether or not the treatment is effective. So one thing I want to point out, a lot of times I have patients call and they'll say, okay, well, I don't really know my PSA number. My doctor says it's rising or it's lower, the treatment's working or it's not. Your PSA belongs to you. You have every right to those medical records. So get your imaging, scans, get your panels, get your testosterone, get your PSA. All of those numbers and all of those records you should have. Now you may ask, you say, okay, well, I have it, but I don't know what to do with it. Well, the more research that you do and the education that you do through PCRI or other avenues will help you understand your own medical records, but also help you determine what other treatments you may want down the pipeline. There's a lot of other tools besides chemotherapy when it comes to prostate cancer. And it's important to know if you have this certain level of PSA, and maybe you're uncomfortable that your PSA is rising, you're going to know that number. But you're also going to know that there's other tools you can use. You can have better informed conversations with your medical team, and that way you have a better outcome. The number one thing I want for all of you is that your quality of life is not surrendered to the concept of getting rid of cancer. Your PSA and all of these scans and all of all this information, and especially the conversations with your medical team, should have quality of life in mind. And that is a very important fact because you matter as a whole person, not just the prostate cancer situation. If you need help with your specific case, you can contact us at pcri.org/helpline. We can answer, questions regarding your case and give you information on specific questions you may have. And that way you have a better outcome with your medical team because you're going to be able to go in there with your questions and you're kind of ready for the conversation. Also, please remember you're not alone. We have tons of videos out here in PCRI with everything that we have going on when it comes to infographics, conferences, videos, YouTube channels, whatever you need, we have these resources and we're here for you. Thank you so much for trusting us, and I hope you have a great week.